All right, everyone. So hi, my name is Karina Mason, and I am the Family Services Worker in British Columbia with the Huntington Society. Today, I am going to be introducing genetic counselor Michelle Lane, who will be discussing the predictive testing process. Undergoing predictive testing is a very personal choice, and in this session, Michelle will help us explore what the science and process looks like undergoing predictive testing for the Huntington's gene mutation. You'll learn who to contact and how to get started if you choose to pursue this process. And Michelle will discuss the different layers involved in making your choice and the supports that are available along the way. Michelle graduated with a Bachelor of Science from St. Francis Xavier University in Nova Scotia in 2008, and she obtained a Master's of Science in Genetic Counseling from McGill University in 2013. She's been working as a genetic counselor with the IWK Health Center in Halifax since October 2013. And Michelle currently works as a member of the neurogenetics team in the Maritime Medical Genetics at the IWK Health Center. Just for a little bit of housekeeping, please keep your microphones off during the session to limit the distractions. And if you'd like to ask a question, you can type it in the Q&A bar on the right-hand side, and we'll get to them at the end. Michelle, I will pass it over to you now.
Thank you very much for the kind introduction. Welcome, everybody. As Karina said, I am Michelle, and I'm a genetic counselor working at Halifax, Nova Scotia. So today we're going to talk a little bit about what genetic counseling is, a little overview of the genetics of Huntington's disease. And we'll talk a little bit about the types of referrals we receive in our neuropredictive testing clinic at the IWK. Again, trying to generalize, I do only work in Halifax, and many of the clinics across the country are similar, but not exactly the same. So there will be some things I talk about that are specific to our clinic that hopefully are generally true for most clinics across the country, but there may be some differences. Then we'll talk about the predictive testing process, kind of what that might look like in a step-by-step process, considerations people might want to think about before proceeding with predictive testing, or things to consider, and then talk a bit about some resources after that. So genetic counselors are health professionals who have specialized training and expertise in medical genetics and counseling. There is a specific master's degree program in genetic counseling, which most of us do have. We work as members of healthcare teams, and our goal is really to provide patients and families with information on the nature, inheritance, implications of genetic conditions. We see patients with family histories of Huntington's disease, but we also see patients with many different types of genetic conditions in the family. So our goal is really to help individuals make medical and personalized decisions about genetic risks. A genetic counseling session can look very differently depending on the indication. Oftentimes, it's a two-way interaction, providing information to the patient, receiving information back, and discussing the implications of genetic risk. So we often obtain a family history, which involves collecting information about yourself, children, siblings, parents, aunts and uncles, and that really allows us to do a risk assessment and to communicate what that risk might be to you of the genetic condition in the family. And it also is an opportunity to teach about genetic conditions and inheritance. Some individuals come in with a lot of background information, others come in with much less. And then there are the implications of genetic testing, and genetic testing has implications and risks associated with that. So our part of our process is to explore that and discuss that with patients and to advocate and support for patients. Now, as you can imagine, no two sessions are the same. We may have two referrals that look identical on paper. Let's say a 35-year-old female with a parent with Huntington's disease looking for predictive testing. That might look the exact same on paper as a referral and look completely different in session. Again, because this is a two-way communication, and the individual's personal experiences are going to play into that. So it is very much, the process might look the same, but the discussions involved may be quite different. I'm not going to talk a lot about Huntington's disease itself, because again, we want to kind of talk a bit more about the predictive testing side of things. So there's going to be some information I kind of cruise quite quickly through, but can always come back to it if you do have questions. So many of you may know that Huntington's disease is a progressive neurological condition. The HD Society actually produces this handout that says, "Have you met MET, Huntington's disease?" and talks about the symptoms involved with Huntington's, and uses the MET, meaning the M, for movement, involving the coordination of movement symptoms that can be involved. E being the emotional side, the mood and behavior type symptoms that may be involved, and then the T for the thinking, the planning, the organization of the cognitive component of Huntington's disease. So I use that handout actually with patients who are learning more about the signs and symptoms of Huntington's disease. Again, not everybody coming into a session will have a lot of information. Others, I rely on them sometimes for their expertise because they actually have a much closer lived experience with Huntington's disease than I do. So again, we may spend more or less time on that in a session depending on a person's background knowledge. Like a bird just hit my window. I'm sorry about that. So the average age of onset for Huntington's disease is between 35 and 44 years of age. It can be variable. So there are individuals who have the juvenile HD with more of a childhood onset. We're not going to focus on that today, as that is kind of a separate category in some ways. And people can present later in life outside of that typical 35 to 44 years of age. So we can have the classical presentation of more of a later onset. So again, collecting family history is going to help us better understand what an individual's personal experiences with Huntington's disease and what their family experience has been. Again, it can be variable, so not all individuals in the family are going to present at the same age or with the same symptoms. This can also be different from one family to another, or individuals within the same family, or we may have two people. I'll touch on the repeat size in a few minutes, but may have the exact same genetic repeat size and present differently. So just to say that, yes, while Huntington's disease in general, the symptoms, the condition can present similar, in the end ends up being quite similar from one person to another. It may present quite differently in a family, and in the predictive setting that can actually be quite important to know, what people are understanding of those initial symptoms in their family, and making sure it's clear that it may not be the same for one individual to another. So Huntington's disease is an autosomal dominant genetic condition. What this refers to is that we have two copies of most of the genes in our body. The gene for Huntington is called HD1. And in order to be at risk to develop Huntington's, we have a typo or a mutation or a gene variant in one copy of the gene, and the other copy does not. So when we have a dominant condition, when we have a child, there is a 50% chance of passing on the genetic change in the family, and a 50% chance of passing on the working copy of the gene. So for an autosomal dominant condition in a parent, there is a 50% risk of passing that on to a child. So here, the purple allele, or the purple, we have a purple individual here who's affected and they have this purple allele. This would be the at-risk allele, which they could pass to a child. So any parent who has an affected child has a 2 out of 4 or 50% chance of passing that on, and a 2 out of 4 or 50% chance of not passing that on to their children. I put at risk because, again, we may carry this change and not develop symptoms so much later in life. So in the predictive setting, this may be something that we learn we're at risk for and not necessarily affected with at this time. So the particular genetic change in the HD1 gene is called a trinucleotide repeat. So if we think of our genetic alphabet compared to our regular alphabet, there are 4 letters: A, T, C, and G. And so within the HD1 gene, there is a CAG repeat that repeats a number of times. This is in all individuals. So people with Huntington's do not have a gene that other people don't have. It's that they have a change in the gene that other people do not have. So it's the number of times the CAG repeats that tells us if a person is at risk for Huntington's disease or not. So you might hear people refer to a number when they're talking about a positive result. This is really that trinucleotide repeat, or trinucleotide repeat expansion number that we're talking about. And every individual would have 2 numbers, one they receive from their father and one they receive from their mother, their biological father and biological mother. Okay. So the number of repeats is really what we're looking at when we get a genetic test result back. So an individual who has 2 copies of the CAG repeat that are equal to or less than 26 has a completely normal result and is not at risk for Huntington's disease. An individual who has between 27 and 35 repeats is not at risk to develop Huntington's disease, but is considered to have an intermediate allele. So an intermediate allele so allele sizes or the repeat number can get bigger when passed from a parent to a child. And this typically is seen more frequently when passed from a male to their children. So the sex of the children is not, biological sex of the children is not relevant. It's more the parent that it's inherited from, where we tend to see more expansion if it's coming from a father than if it is coming from a mother. It does not mean it will expand, but it can. So we differentiate intermediate alleles because there is the possibility that a child could inherit a larger number than the parent has and may be at risk. So the 36 to 39 is considered a reduced penetrance allele. Oftentimes with this allele, we may see a later age of onset in a family. So meaning that we may not see that classical 35 to 44, and maybe people aren't developing symptoms even until their late 60s. And so if we live long enough, if we live into our 70s and 80s, we would expect these individuals would have symptoms. But again, it may not be the classical picture. Individuals who have a 40 or more repeats are considered to have a fully penetrant allele and are expected to develop symptoms of Huntington's disease at some point in their lifetime. There are still some families in which the onset is not in the classical picture. It may be not till after the age of 50. We do know there's a percentage of individuals where we have a fully penetrant allele, but the onset's not till later, often after the age of 50. And that's not necessarily because of a reduced penetrance allele. So again, taking the family history and seeing, ideally, we would have a copy of a result for someone in the family so we know what repeat size we're dealing with is all very helpful in the predictive testing process in order to help people anticipate what the results might be. So who might we see in the genetics clinic? So I want to touch on a couple of things we might see that we're not going to expand on today. And really what we're going to expand on is the second category. So we may see individuals in which a neurologist has seen a patient. They feel the patient may have early signs of Huntington's disease, or they may have symptoms of Huntington's disease. And for one reason or another would prefer that they come through the genetics clinic to do the testing. So perhaps they feel that they haven't had time to fully discuss the implications of the test result or want the patient to explore that more before doing the testing. Or perhaps there's some family dynamics in which they just feel it would be helpful to have the genetic counseling process involved with it before doing the testing. So we may see individuals from a diagnostic testing, so meaning there are symptoms present. Other times individuals may be assessed by a neurologist and they may actually be the ones ordering the genetic testing. And we may see them after the fact, kind of more down in this third category where it's just genetic counseling to review a test result that's already been done or a new diagnosis in the family. The predictive setting is really individuals who are at risk, who are potentially interested in exploring the option for genetic testing. These individuals would be asymptomatic typically, so meaning that they do not have any symptoms or any clear symptoms of Huntington's disease. They may be wondering about some things that they're seeing in themselves that perhaps this might be an early sign. Others may be completely healthy with no concerns that they have symptoms, but would like to know their status. Okay. Again, we may just see people for genetic counseling. The testing may have already been done in the family. They may very clearly not want to have testing, but are looking for more information about their risk. They might have health-related questions. They may never have had the opportunity to sit down and really explore with someone what Huntington's disease is from a genetics component or from a symptomology set of or from a sense of what the symptoms might be. So again, or that might be someone who's known their status for a long time and they're just coming in to explore family planning or family implications for their result. Okay, so we are going to focus now on the predictive testing process. So this is a general outline of how it typically works. We're going to go through these point by point and kind of touch on what's covered in each section. Now, one of the biggest things that I will say is probably that may be different from one clinic to another in this country is really the timeline between how long this process can take. Unfortunately, our wait times in Halifax are not what we would love them to be. They are longer than we wish. And so the referral to the first appointment to the second appointment may all be quite different from one clinic to another. So if you are wondering about this process and have questions about trying to get a better sense of what that timeline might be, that may be better directed to your local clinic, which we'll talk about near the end. Okay. So typically the referral will come from a healthcare provider. So either a family doctor or sometimes a walk-in clinic, given the state of how difficult it can be to get a family doctor, or a nurse practitioner, asking for us to see a patient who may be interested in the predictive testing process. So that referral comes in, we review it, we triage it, and some clinics may actually send you some paperwork. So you may get a confirmation that your referral has been sent and received by the clinic, and this is the general wait time we would expect before you're offered your first appointment. It should have a contact number for your clinic as well, so if you had questions, you would know how to reach them. We do not typically send family history questionnaires, although some clinics might. They may send you some paperwork asking about your family history so that they have a bit of a sense of what the family history and the pedigree look like prior to the appointment. We may also send releases of information. So sometimes if we feel it would be helpful to have information about affected family members, we're not able to access those records without permission. So sometimes paper will be sent prior to the appointment asking for the person in the family who's affected or their next of kin to sign, allowing us access to get their medical records. So just to say, once your referral is received, if you do get paperwork, try to read that closely, make sure there's nothing there that you're missing. Some clinics may have things in that letter that say, if you do not refer these forms, we will be closing your chart. I suspect that's not the case, but again, just take a quick look through that, make sure we're not missing anything. Our letter typically says there may be paperwork included, please complete it, and oftentimes there's actually no paperwork in there. So if you do have questions in reading that letter, there should be a number for you to contact. Okay. In our clinic, unfortunately, at the moment, we fluctuate from time to time. From the time of the first referral until the first appointment, maybe up to a year-long wait. Do we want that? No, we don't. And we're trying to make strides to improve that. We have been closer to 9 months at periods of time. We are working to reduce that wait time. But again, that may be very different depending on where you are and the genetics clinic you're looking to be seen by. But keep in mind, there may be quite a wait from the time of referral until the time of that first appointment. Okay. The first appointment is really an opportunity for information gathering and information giving. So some of the information I covered in the first of this appointment, or it's the first of this presentation, would really be information I would be giving at the first of the appointment, with more emphasis depending on what the individual already knows or what they do not know. So some first appointments for an individual who has not grown up with a close relative with Huntington's disease, maybe they didn't have close contact with them, we may spend more time on that side of the information giving and gathering, more on the information giving, sorry. An individual who has grown up with a parent who's affected and has all that information, they've been reading about Huntington's disease for many, many years, we're probably not going to spend as much time on that, and may focus more on the genetics and the family history and the exploration of the motivation for why an individual is pursuing testing at this time. So that first appointment may look quite different from one person to another. Ours are generally 75 minutes long and only with a genetic counselor, not with a medical geneticist who will be involved in later appointments, okay? So really one of the most important things during that time is assessing the family history and assessing the individual's risk. You know, do we know the status of the parent? Do we know this person is at 50% risk? Do we not know that status? And therefore the person's risk may be 25% at this point in time. So really trying to assess that particular individual's risks, okay? In the information giving, we'll talk about what is Huntington's disease, what are the symptoms, what is the age of onset, what is the mode of inheritance. So really that's a lot of the information in the giving section of the information giving, sorry, of the first appointment. And then another big part of that, again, depending on an individual who might be coming in with a lot of background information, then we're going to get a chance to start exploring those motivations for testing testing probably in that first appointment. So why are we here today? Why am I seeing this individual today and not a year ago or not a year from now? So why is this the time that we're seeing them? What's changing in their lives? What has changed that maybe brought them in? Maybe they just were waiting for a particular age. So really trying to explore what's going on in that person's life, why this information might be helpful for them, what are their fears in this process. So lots of back and forth conversation, which is why, again, that snowflake kind of slide really just is another great image of that, how different these sessions can really be from one person to another. Now, the little image I'm using on the left is of two people around a table. That might be the case. You may be seeing a person in person, or it might be by telehealth or Zoom. So for us, our clinic has been using telehealth services for many, many years. We see patients in Nova Scotia, New Brunswick, and Prince Edward Island. And therefore, because we don't need to do a physical exam, we don't bring them in person to do that conversation unless they wish to. So we've been using telehealth services, meaning that I would be on a camera in my hospital. They would go to a local hospital and be on camera there. Since the pandemic, we've been using much more Zoom for healthcare, and therefore you may actually be in the comfort of your own home, or a family member's home, or a space that you feel safe in that's not actually a hospital setting. So finding out, I don't believe many clinics do phone appointments for the first. It's not our preference, as it is, as you can imagine, not having a visual can be challenging. So generally speaking, we try to have some sort of video capability, but I'm sure exceptions have been made and would be made in the future. But ideally, we would have that face-to-face connection. So then after that first appointment, generally speaking in our clinic, it's about 2 to 3 months before the second appointment occurs. So we may send you home with those releases of information after the first appointment. There are some documents that I like to share with patients to do some reading about between the first and second appointment. There's one that I'll show you at the end of this presentation about personal perspectives on genetic testing produced by the Huntington Society of Canada. So I might share that with patients to have a read over, and we might touch on that at the start of the second appointment. So again, depending on where you are, the timeline between first and second appointment may be very different. There are some circumstances in which we have had one appointment and then offered testing, but that tends to be the exception, not the rule. Typically, there is a second appointment to further explore motivations. So again, further discussion in this second appointment, as well as exploration into the motivations for testing. There's still information giving. We want to talk a little bit more now about the process of the blood collection and how that, a little bit more focus on if the patient is keen on proceeding with testing, what that results appointment is going to look like as well. And then exploring a little bit more about how a person might feel or anticipate they might feel getting that positive or negative result. So, have you been through a process like this before? Have you gotten difficult news, and how did that look whenever you were coping with that information? So what are your coping mechanisms? How do you imagine those playing into receiving your result? We're going to spend a bit more time. We might cover it in the first appointment, but we might talk about it a little bit more in the second appointment as well, because we're really starting to focus more on the results side of things in that second appointment. Again, the logistics of testing, meaning the paperwork, all that, which we'll talk about in a minute. And then again, exploring more of the fears and concerns. This second appointment, again, typically would happen in person or through telehealth or Zoom. And again, depending on where you're being seen, that might be different. Okay, I have had some patients who have been eligible for Zoom, which would save them some travel, but actually really preferred to do the process in person, and therefore chose to come into the clinic to actually be seen because that was their preference. Okay, so if that is your preference, don't be afraid to speak up. Really, this process is about making you feel comfortable, making the person feel comfortable in that whole process. Okay. After the second appointment is generally when we will do the sample collection. So for us, we will often, because we do much by Zoom, by telehealth, we may mail you your requisitions, or we may email the requisitions to a patient for them to do the blood collection close to home. Again, this might be different from one clinic to another. For us, if I am seeing a patient in New Brunswick and they live in Fredericton, well, then we'll go into the Fredericton Hospital or a blood collection site in Fredericton with the paperwork to do their blood collection there. The blood collection is like any other blood work in some ways. It's a 5 ml blood collection typically. You do not have to fast. and doesn't really feel that different from other blood work. The difference is that then what we're going to do is we are going to extract the DNA from the blood and look at that repeat size. Okay, so again, typically after the second appointment, you get the paperwork for the blood collection. And then our next point of contact from there is typically a phone call prior to the day of the results appointment. So from the time of blood collection till results, for us, it's about 2 months in our clinic. Sometimes it's a little bit less, sometimes it's a little bit more, but generally it's 2 months from the time of collection. If the paperwork gets sent and it's not a great time and a person chooses to wait a couple of months to do their blood collection, well, then obviously that's going to delay the process. And there's nothing wrong with that. It's just a matter of it's 2 months typically from the time the blood sample is done in our clinic. And it might be slightly longer or slightly shorter depending on where you are. Okay. So we do a pre-results check-in. I think this is pretty common as well. This is often by phone. So our results clinics in our clinic typically happen on a Monday afternoon. And so Wednesday, Thursday, Friday of the week before is usually when I will call to check in and see how everyone's doing. Are they feeling ready for this result? Do they have any last questions? Any logistical questions about where to be, what time, and then we review again how the results are actually going to be communicated. So just again reviewing that I'm going to be pretty brief that results appointment day. So we're not going to talk a lot about the weather. We're really going to get to it. But the first thing I do is to check in to make sure a person still wants the results. So we're reviewing all of that in this pre-call. The results of the testing are sealed in our clinic and in most clinics. So meaning that the genetic counselor who is calling you will not actually have looked at that result when they're making that phone call. And that protects both the patient as well as the counselor and the physician involved in the case, meaning that you're not trying to read into my voice about if I sound happy or sad or worried or anything like that, or I'm trying to coerce or anything, because I do not know your result. And as well as if you ever decided not to receive your result, I don't know what that would have been, and I don't have any I don't have any sway in, oh, but if you got it, it's negative. I want it, like, please come meet me. There's none of that because I do not know the result. And again, that is protection for you, for the patient, as well as for the clinician involved. Now, what I haven't mentioned is that in that second appointment, typically you will have met the medical geneticist as well. Our clinic, it's only about 15 minutes at the end of the appointment. They're going to be attending the results appointment as well with the genetic counselor. So we want them to have met the patient as well as gotten the patient an opportunity to ask the doctor any questions. But they do play a smaller role in our clinic, and that might be similar in other clinics or not. You may meet the medical geneticist the first appointment, or maybe they're more involved in the process. So for our clinic, it is more counselor driven, and the physician is involved in the later part of the second appointment and then present for that result appointment. After the pre-check-in, I also check in with the patient to say, is it okay for me to send a letter to your family doctor to make them aware that you will be meeting with us in the near future to review your results, or the date, so we'll give the date of the result appointment so that they're aware if they get a call from you asking for a more urgent appointment, that they'll be aware that you've recently received this news or news of a result. The result will not be communicated in that letter. It's just an information about the date and time of the appointment, and that a result's going to be reviewed then, so that if you again are trying to reach them, they understand that you've recently received this news. Okay. And so then is the day of the result appointment. Again, this may happen by Zoom. This may happen in person. If you did the first 2 appointments by Zoom and then chose you wanted your results appointment in person, that could happen. I think more and more patients have been doing the whole thing by Zoom. I think they enjoy being in the comfort of their own home. But again, if that's not your wishes, please communicate that to the team so that they can ensure that it's the most comfortable situation for you as possible. This is a difficult news to receive, and so anything we can do to make that easier, we want to make sure we do. The results appointment, so typically just before the results appointment, the day of, I will review the results. So meaning I will look at that result to ensure that the patient's name is there. I don't have a different result in there, that it's straightforward. So I do look at that result slightly before I go into the room with the patient in order to ensure that I'm not looking at another patient's result or there hasn't been some sort of error there. in our clinic, I don't open an envelope and then give you your results. I actually have the piece of paper inside a folder, and there isn't a big reveal. I actually had a patient recently tell me how anticlimactic it was because she had anticipated that I would be revealing it in an envelope, which is really understandable. So just if you do have questions about what that's going to look like, you can ask the counselor involved, like, will you be opening an envelope in front of me, or how will that work, if that's helpful for you to know. Again, I tend to ask at the results appointment, do you still want to receive your result? If the answer is yes, then we get right to it. Unfortunately, you've tested positive and you are at risk for Huntington's disease, or you've tested negative and you are not at risk. That appointment is booked for 45 minutes in our clinic. It may be the shortest appointment, or it might be a long appointment. And that might be completely different than a positive or negative that can occur. So meaning I've had very short positive result appointments. I've had very short negative result appointments. I've also had very long positive result appointments. And I've also had very long negative result appointments. So really that appointment will be as long or as short as you desire. And again, we typically, the next step is to do a follow-up phone call, but if ever there was a second appointment needed to review this in more detail, we'd be definitely happy to do so. If you wanted a copy of your result, you can request that, and you can leave with a copy of your genetic test result. The follow-up call, so after the results appointment, we may, if a patient has tested positive and they would like to see neurology for an assessment of symptoms, that can be done. We can refer you on to a local HD clinic for an assessment by a neurologist. Some individuals may have already seen neurology prior to seeing us. They may have said, I'm kind of concerned I have some symptoms, so I want to see neurology first to assess that. And if the neurologist has said they don't see any clear signs, then the patient might still choose to go through the predictive testing process. But with a positive result, some individuals will choose to have that assessment then. Others might say, I'll call you whenever I'm ready for that, whenever I think I want to be assessed by a neurologist. Again, this one's typically done by phone and usually about 2 weeks after the results appointment, checking in to see, do you have the supports you need? Did how you anticipate feeling pan out? Do you feel differently than you expected? Are you struggling with this news? Have you shared it with other people? Are you struggling to share it with other people? So really trying to check in, see how everyone is doing, and then trying to put in place any supports that might be needed that may be missing. Okay. So I didn't talk about this in the outline, but generally speaking, we suggest a person take a support person with them through this process. Ideally, they would be with you the whole way along the process. For some individuals, they may come to the first appointment alone, and then we'll talk about, bringing a support person for the second appointment. This is primarily, many individuals want to have a support person present for the results appointment, and it's really helpful for that support person to be at a prior appointment, so they've also had the opportunity to hear how the results appointment is going to work. They have a chance to ask questions, because what we really want is for that day of the results appointment to be the focus on the patient, not trying to answer the support person's questions. Now, that being said, if the support person has not been present for the other appointments, and they are asking the questions, we do tend to check in about, are you okay with us answering these questions? Is this information you want to hear right now? But it is part of the reason we ask for someone to bring a support person along the process, is that if they want them there for the results appointment, it is helpful for them to be present for the other conversations as well. So that will be something that if you attended your first appointment by yourself, that might be explored with the team. One of the things about this testing, one of the physicians I work with always says, I can always do this testing, but once it's done, I can't undo it. So why now? Is this the best time for you? Is this the best time for your family? And we'll explore, we'll often explore that at the first appointment, but thinking about that, this process may take over a year. And where am I going to be in a year's time? Is it going to be leading up to, say, a holiday time? That's really important for me, and I'm not going to want to get news then. That's not to say that you should delay your referral, but I think that is something that if you're looking like, okay, my first appointment is now, my second appointment's going to be in November. Oh, that's going to leave me a result right around the December holidays. Is that really is that going to be good timing for me? Well, maybe I delay my blood collection, so I'm not receiving that news at that period of time. Am I planning a family and this information is really important to me? Do I need to know my status before I choose to have children? do I want to have children before I know my status? Do I not want this to have any implication in what I do with family planning? And therefore, I don't want to know now. I want to know down the road. So exploring, the timing of all this, and is it right for you in your life, either from an age-related perspective or just general, the last 2 to 3 years have been really stressful for individuals in general with the pandemic. And for some people, maybe that has added to wanting to know their status. And maybe for others, it feels like if I add one more stressful thing to my plate, it is too much. And so knowing kind of where you are with your own with an individual's own stress levels is really important to think about. And it's not to say that if you start the process, you have to finish it. You can have the first session and maybe in 3 years' time, you have your second appointment. That there's nothing wrong with that. So I think taking your time and making this process what's good for you is really important. Some individuals may have questions about insurance. Will this impact my insurability? Have I tried to get insurance? Can I then use this negative result to help with that? Those are things that can be explored in the genetic counseling process. Sometimes we will not have all the answers for that. And it may be that we say, maybe you could ask a hypothetical question to a broker. You may want to seek information from someone in the insurance world, as we may not be the best people to answer specific questions, but generally we can talk a little bit about what the laws are and that sort of thing. So I'm just going to hold this over here. What am I going to do with these results? How is this going to impact my day-to-day, or maybe more of a larger life decision sort of perspective? Are there big decisions in my life that I'm putting off because I want to know my status? Or are there things I want to do first before I know my status? How is this information going to be helpful for me? Am I ready to know I'm not at risk? Am I ready to know that I am at risk? All of these things are good to think about beforehand, but also recognize that you might need support in exploring these things. And therefore this, going through the predictive testing process might be super helpful. Again, why do some people choose a predictive testing process? It is very individual. I think one of the most important things to keep in mind is that many people actually choose not to know their status. Those are individuals I don't typically see, because the thought of predictive testing is so not what they would consider, that they're never really come through our doors, to be honest with you. And that's okay. I think knowing that this is not information that would be helpful for you is great. This is not good for you. I'm not interested in it, and that's great. If ever you're looking for information, be more than happy to see you in a genetics clinic to discuss that information. But it is okay to not want to know your status, and many people feel that way. Other people, it's the family planning, decisions about retirement or financial planning. I think individuals who describe themselves as planners tend to be people we see a little bit more of in our clinic, because this information might impact future decisions. And so they want to know in order to make some larger decisions. Another thing we hear quite frequently is the burden of not knowing. So yes, I understand I may test positive, but the risk of testing positive far outweighs my ability to cope with not knowing anymore. So there's that level of uncertainty that for some people can become unbearable at times. And then that's when they know, I can't live with the uncertainty anymore. I need to know my status. And that's sometimes as much as people can verbalize, but is a very legitimate feeling. Okay, other people might be worried about symptoms of HD, especially those initial symptoms. There's a wide list, and it's not always hard to check a box or two on those early symptom lists. So individuals may be at risk and be concerned about symptoms, and then that kind of pushes them towards the predictive testing because they're starting to worry more about symptoms. I want to make sure we leave lots of time for questions here. But other things that patients have commonly said, some people have a lot of difficulty adjusting to the result. This information is present from the moment of conception, but we live much of our lives without knowing it. So then to suddenly learn the information one day that, yes, it was always there, but now I know it, it's not always as automatic. It takes time to adjust to those results. And that can be both positive and negative. And some people really struggle with that. There's also sometimes for some people this thought that it's taken away hope that maybe they wouldn't develop symptoms later on. Now I know I'm positive, there goes my hope. So I think, for those people, maybe the testing process, maybe they didn't go through with the testing process, maybe they chose not to have the testing, or maybe they were ready, but it was still really hard to adjust to that. Okay. And then, yes, there is guilt sometimes for people who test negative or for people who test positive, thinking about what their future might look like for a partner or children, or for their siblings. And that can be, you know, I tested negative and I know my siblings at risk, and now I know I don't have to go through this, and I have that survivor guilt in some ways. So where do you go from here? If you are interested in the in predictive testing or genetic counseling, you can ask your healthcare provider to refer you to a local genetics clinic. If you have questions for a local genetics clinic, wondering about what the process might look like there specifically, the Canadian Association of Genetic Counselors has a link that says find a clinic, and you can find the clinic that's closest to you in order to know where to look. The Huntington Society of Canada has some wonderful resources under the Learn About HD and the Connect page. There is an at-risk/gene positive virtual support group that actually our moderator Karina is involved with. It is a closed group, and I believe the next session will begin in the fall of 2023. But I'll just actually pop it up here. There is a link on the HD website if you wanted to get more information or apply for that. The personal perspectives piece here, that is a document that's available on the HD Society website. That is a good one to review if you're wondering about the predictive testing process and maybe want to hear more about what other people's perspectives have been. And then there is some more information about just general genetic testing information in this particular handout here on the right. Pardon me. Okay. I want to give some time for questions. So thank you very much for your time. Thanks for listening. And I am going to end my slideshow here so I can see better.
Awesome. That was great. Thank you so much for all of that really helpful information. We have a few questions that came in, and if anyone else wants to ask some more questions, we have the chat function just on the right-hand side. So our first question, someone is asking that they were tested way back in the 90s when they were in their 20s, and they're aware that there's a small margin of error. And at that time, the test results had to get sent to BC. So she's wondering if she should redo the genetic test again now that technology has changed, or does it make a difference?
Yes, there is some, so we were looking at repeat sizes, which are kind of like bands. So it is a tricky result. Sometimes there is some interpretation there that can change. And the testing has changed a little bit over the years. What you might do is contact the local clinic where you were tested to say, could you review my result? Is there any reason for me to be retested? I would be surprised if there was reason to do so. I wouldn't say that in general, if you tested when you were 20, that you should be retested at 40. But if ever there was an intricacy within your own result that maybe you thought you might want to check in on, I would suggest contacting the clinic where you were seen just to double check. They can then review your exact report and let you know if maybe there was reason to do it again. I would be surprised if that were the case, but it could be that there'd be reason to do it again.
Cool. Linda, I see that your hand is up. If you'd like to, you can unmute your mic. And if you'd like, you can also put your camera on completely at your discretion so we can ask Michelle your question.
Hi, Linda. I can't hear you yet, but I see your mic's unmuted.
Okay, we'll give it a sec. Linda, if in case you do have another question, feel free to unmute yourself again. We'll go to the next one. So if a twin has Huntington's disease and the other does not show signs, should they get tested as well? And this is about fraternal twins.
Fraternal. So fraternal twins are just like siblings. So meaning that you share DNA the same way that a brother and a sister would. So their result does not change your risk based on your parent status. So if twins have an affected parent, they both have a 50% risk of potentially having the expansion and developing symptoms of Huntington's disease. So regardless of their siblings' result, they are still at 50% risk. So in some families, we do see, let's say 4 children, 2 test positive, 2 test negative. In some families, we see 4 children, 3 test positive and 1 test negative. In some families, we see 4 children and they all test negative. So it's 50% with each pregnancy. And so for fraternal twins, we treat them the way we would treat siblings. So it would be a 50% risk regardless of the result of your sibling. So if you were concerned that you might have symptoms of Huntington's disease, there are kind of 2 routes to go. You could potentially get referred to a neurologist for an assessment of symptoms to see what their thoughts are. They may be able to give more insight about that. If that doesn't feel like you wanted what you were interested in and more so wanted to know if you'd inherited the genetic change, then the referral to genetics probably makes good sense if that's something you wanted to explore.
In the cases of identical twins, for example, I can imagine there can be some ethical complications if, say, one sibling wants a test and the other maybe doesn't. So how is that process navigated? Because I would imagine that the person who wants a test would have the right to access that information, but I can also see that it would create a bit of a sticky situation.
All of which we would explore. Absolutely, Karina. That's a very good point. Identical twins is a very different situation. And that gets explored. So thinking about, what that might be like to, some identical twins are very, very close, some are not. To learn you are at risk and subsequently learn your siblings at risk, but know they don't want that information may be a burden someone doesn't want to carry, or maybe they decide, I need to know my status. I know what this will mean for my siblings. So how are we going to navigate that? Do I go through the process without telling them? Do I tell them and let them know I won't communicate that back to them? We explore all that. And I mean, there's 100 different other things within that. But it's very tricky. And a similar situation may be for individuals who are young and their grandparent is affected, their parent doesn't know their status yet, and they want testing. And so a positive result for them would subsequently learn their parents' result. So again, it's a similar situation of you are learning someone else's status in the middle of this who may or may not know their status. And that doesn't mean you don't have the right to know. It means making people aware of what that might look like for them, exploring how that might feel.
Right. Linda, I see that your hand is raised, so I'm going to try and unmute you, or you can unmute yourself. There we go.
Yeah, okay, thanks very much.
Hi, Linda.
Sorry, Michelle. Hi, I'm Linda McLaren. I'm a genetic counselor in Calgary that also works with the predictive testing process. Hi. And I just wanted to comment on the person saying if they were tested in the early 90s, was there any reason to be retested? And of course, Michelle, you're too young to know that prior to the, and I'm too old, but prior to the discovery of the gene, of course, we did testing via linkage. So people were given a probability of 98%, 96%, those types of things based on linkage. So for those people, there still is a, in quotes, as that person was describing, a margin of error. So people tested prior to when we were doing direct gene testing may want to, again, their choice, but may wish to check back to have the testing. So I just wanted to clarify for that person since they mentioned being tested in the early 90s. Thanks. I'll get off.
Thank you, Linda. That's wonderful.
No, my pleasure.
And that would be true for everyone then, Linda, correct? So that would mean across the country if you were tested before. Not
around the world.
Exactly. That's it, right? Thank you so much for that, Linda. I appreciate that.
No problem. And it's early out here, so I'm sorry, I'm not camera worthy yet. Yeah.
That's okay. That's okay. So Michelle, we have time for one more question, and then we'll wrap up with our video. But we just wanted to know if it's possible to have multiple people tested at once and get results together, such as different family members and siblings, and maybe quickly, what are some pros and cons of doing the process with another family member?
Yeah, we tend to. Every clinic is different, every counselor is different, every family is different. So I do have a family at the moment who it's not for Huntington's, but it's for ALS. There is a predictive testing process they're going through for ALS and have expressed that they are a family unit. And for them, they are such a unit that they are insisting that they be tested together because they feel that is how they can best support each other in one process. We do caution that. I mean, getting your result is we can anticipate how we might feel, but it doesn't necessarily mean that's how we will end up feeling in the long run. We may think we will handle it this way, and in the end we don't. And then to throw on the dynamics of another person on top of that, is that going to be helpful? And so we would explore that. In the cases where I have tested more than one person at the same time, I have still done at least one period of time and at a one-on-one with people in that group. So meaning that I touched base with the two siblings separately to ensure that both really truly did want to have this together. And I believe we actually had an extra session as well. So it's not the most common, and there's lots of cautions we talk about in the session about the intricacies of that. But it is something you could explore with the team who's seeing you.
Awesome.
Yeah.
Great. Well, thank you so much. We're really grateful that you were able to share all this knowledge and information on such an important topic. Now we have a few minutes dedicated to some more community awards, and then our next session will begin promptly at 2 p.m. Eastern. So I'm going to go ahead and share my screen.